Welcome to the Pacific Business Group on Health Intensive Outpatient Care Program quarterly learning session in Oakland, California. We have speakers from our medical groups from Wave 1 and Wave 2. They are here today to share their best practices. We also have members from the Pacific Business Group on Health Clinical Advisory Board to share their expertise as well. Lisa is the director of the Intensive Outpatient Care Program at Pacific Business Group on Health. Lisa will open up with an introduction, and also you'll see on the first slide here that Lisa is presenting the names of all of our groups, Wave 1 and Wave 2. So Lisa, go ahead and start our kickoff.
Some of this will look familiar to you, but this is who you are, and this is where we are. So we're at about 5,500 enrolled right now. We are hoping to get most of the way to our 27,000 target. Well, not quite there by the end of the grant, which is June 30th, 2015. We started enrolling late, and we are very hopeful that there'll be no cost extensions and we'll be able to keep enrolling and get a larger sample size and provide services to the patients who need it a bit longer. We have an average disenrollment rate program-wide of 10%, but a couple slides in we're going to show you variation by group. And we have metrics that we will have to show to CMS. We report them quarterly, and then we will be measured against that in the mathematical evaluation as well as in our final report. So we're able to get a lot of the data. And we just finished a report for Q7, so you can see that we have accomplished a lot, and we're very proud of that. We've been able to get the new medical groups up and rolling much sooner because Wave 1 were guinea pigs, and they were gracious about it. And with CHCN, we've expanded to the safety net, so we'll get to test the model on a slightly different population. And we're getting closer to having a consolidated cube that will allow us to measure utilization. And one of the things that is slowing that down is that when we get the data from the provider groups, there are often a few iterations that have to happen before it meets the QA tests. Here's what we've learned. The data will show when Rob's looking at it when there's been a flattening or a slight downward slope in enrollment, upward slope in disenrollment, et cetera. And we usually take that as an opportunity to talk with each of the groups. Actually, no matter what, we talk with each of the groups about how, a comparative analysis of their group with all the others. But it does show, and those are big shoes to fill and really important. And we are seeing that as programs move from implementation into stasis, there are some staff transitions. We sometimes will talk to the groups about how to negotiate those transitions without having a visible effect on any of the run charts we're about to show you. And then we've talked before in these meetings about the culture change that goes with working in an outpatient setting and some of the loss of staff and replacing. Again, it shows in the data as well, and then we find out that's what it's about. So we're moving from a build mode to a monitoring mode, and that will be more robust than it's been. We're still getting some of the second wave medical groups up and enrolling, and we stage that so that we can concurrently be giving you feedback on how you're doing. We'll show you the metrics in a minute, and getting the new groups enrolling without having to do one or the other. We're going to be monitoring guardrails, and these are important, as you know, because these are what we say make IOCP different from other care coordination and disease management programs. So we do monitor those fairly closely and then give you feedback. There's a reason. We also report them to CMS. So just asking you to bear with us. We're going to be doing visits to all of the sites. And the sites that have been visited so far by Lori and Amit have been really pleased with the outcomes. But this will make its way across all sites, starting with Wave 1, and then we are looping in some of the Wave 2 groups that have a significant enrollment at this point, like St. Luke's, for example, or ACN. So you can expect that. Everybody else will get through Wave 1 before we do that. And we're planning for sustainability. We want your programs, as well as any primary care redesign programs that are synergistic with IOCP, to continue after the grant. So we'll talk a little bit about that in a minute. It's going to be fairly high level at this point because we're going to be working with our clinical advisors before we get down into the detail. And at that point, we will present it to each group in a leadership meeting, the calls we have every couple weeks or every month. So program monitoring, this is what, these are the metrics we're looking at, but these are the 4 big buckets that we're looking at. And then drilling down a little bit, we want you to see that it's objective. We want to be transparent about what we're looking at. We do this on data, operations, and clinical facets of the program. One of the things, and we use red, yellow, and green, this is not static. It's going to change every month depending on what's going on in your group. It's also not meant to be punitive at all. It's just a way of us giving you feedback so that you can make mid-course corrections and you know where to do that. I will say that in general, a lack of transparency into your program, if you're not returning phone calls, emails, if there's not a lot of contact that lets us know what's going on, we do, that becomes a red pretty quickly. So, absent a lot of these other variables, and then we're trying to deal with that fairly directly with those programs. And this is what Lori's done. This is something you've seen and you'll continue to see. So again, not meant to be punitive, but we are working on enrollment to meet our obligations to CMS. So we do think it's necessary to give you this amount of detail. And our enrollment's going to pick up as more of the groups come online and as we continue to coach on best practices. So we will do better than that, we hope, but right now that's where we are. So this is where we are enrollment-wise, and you've seen this before. We'll continue to show it to you, and then we also have by groups. But anyway, this shows you where we are by the amount of time you've been enrolling. This is the PAM levels. So Rob can answer any detailed questions you have about this. But basically, it's showing you where we were, the blue, where we were when we started the program. This is a small sample size because it's a small sample size that's been able to have follow-up, or at least did within the CMS reporting period. But we are seeing movement to higher levels of enrollment. And Rob said about a half have shown improvement or change upward. A third are static, and 10% or so have shown declines. And you can also talk to our advisors about that. This is what we think makes our program a little bit different, is measuring how engaged the patients are and getting them to the point where they're just doing all on their own and don't need a lot of coaching. Disenrollment, you can see variation by group, but overall it gets us to 10%. This is really meant to be a teachable moment. So this is pulled out of the EA tool, and we think that there's variation in how thorough we're getting the data. So we want to encourage by showing you this and showing you really where the gaps are, that this is going to get you to self-reporting a little bit different if you haven't been. We've gotten definitions out. We're trying to do something about the ambiguity. And we'd like to see all of these go up. And then this is the PHQ scores. I'm surprised personally by the number of people, the large number of people who only have minimal depression. And then As I mentioned, we're doing some sustainability planning. We're working with Wren Health on that. There are a series of trainings that we're planning that we are going to work with our clinical advisors on before rolling them out. We're not going to put a lot of meeting burden on anybody. What we're doing is going to target different roles within your IOCP programs, but there's no single person that's going to be asked to attend a lot of new events, and we're trying to minimize travel as well. So I'm going to go on and introduce our first speaker. He has been a national thought leader for a very long time and is at Stanford now and is working to drive innovation in all kinds of care delivery. So with that, I'll introduce Dr. Arnie Milstein.
I thought we'd anchor this around this picture. This would be a good thing to open up with. This is a picture of somebody who's her peers are not that far from where we are at this moment. They're scattered throughout the hotel, and they represent a big chunk of Americans who aren't unemployed. They're not impoverished. They make an okay living, particularly in these bigger hotels that, where the wages tend to be not great, but reasonable. But she, like many Americans, is a service worker, and she's got a problem. And the problem is that about maybe 12 years ago, she stopped making, even with her annual wage increases, she stopped making enough money to be able to pay for health insurance policy for herself and her kids. And the answer is, we got to figure out, there's really only two plans. Number one is, do what you can at the margin to incentivize your patients to do what they can do, which is basically to take a little bit better care of themselves to the degree that's within their control. And then secondly, pick the more cost-effective doctors and hospitals. Or you can simultaneously try to put more pressure on doctors and hospitals to get more health with less. And I thought we'd talk about that, since all of you represent the sell side of healthcare, the delivery side of healthcare. And so I thought we'd sort of talk about, how to give you sort of a frame for thinking about how to respond to this social pressure. And IOCP is a perfect platform for sort of framing the problem. So fundamentally, more and more Americans are saying to their politicians, could you please get doctors and hospitals and everybody in the healthcare supply chain to do a little bit better every year at getting us more with less. Think of it as the analogy in the health industry of Moore's Law in chip manufacturing. Now, you don't have to hit the same level of cutting the cost in half for the same level of output every 18 months, but you've got to begin to move in the direction that other big American service industries have moved. Once they, were subject to intense competitive pressure, as the commercial airlines were subjected to about 30 years ago, and B, once they have what's called electronic platforms underneath their activities, so you have a prayer of using modern management techniques to every day in every way deliver more with less, which is what in other industries that once they've got that in place, and it's taken them about 10 years to figure out how to use these electronic platforms, but once they get them in place, they generally have been able, and again in service industries, not to reproduce Moore's Law, but to increase their annual productivity gain. There's the amount of output you get, in terms of, what's our output? Our output is health, right? Health or quality measures. They're able to essentially every year increase that with the same amount of money to the tune of about 3 or 4%, or the way of putting it, I'm going to frame it differently right now for you, is other industries have been able to achieve, without any slowing of their rate of quality improvement in terms of what they do for customers, they've been able to reduce the total cost to their customers by 2 to 4 percentage points every year compared to the prior year. That's think of it as the service industry equivalent of Moore's Law. That's what American politicians, and reflecting ultimately people's desperation over affordability and quality of healthcare, are going to be asking you to do. So that's your job. Now, but last year I wrote a paper with a couple other colleagues looking at the experience of in JAMA, looking at the experience of the pioneer ACOs. And I know that there's some of you in the room. And I love this slide. This is I call the money slide. This tells the story. This was from the results that CMS published. And each one of those bars is a different Pioneer ACO. And the blue bar is how much health insurance, how much risk-adjusted health insurance fuel per Medicare beneficiary per year was being burned at baseline. So some of them, like the one at the very top, was just burning a ton. What is it, 15,000 per Medicare beneficiary per year? And there were some that were super lean, so they didn't, you'd think they wouldn't have much baseline fat. Look at number 24, kind of a 25% of the way down. They were only burning, what was that? Was that say 8,000? Yeah, I think about 8,000. So that's and then the green or the red tells you whether compared to the control group, they actually achieved that 2.5 percentage point, a lower cost relative to, let's say, ambient trend. And as you can see, about 30% of them did great, and maybe 25% of them sort of a neutral on affordability, and then a minority, but a big minority, actually lost ground compared to the control group, which tells us that this is hard to do. Our industry is young in its use of electronic information systems to get a sense of what's going on and to be able to manage. And also, we've never, unlike a lot of these other industries, we've never been under intense pressure across all of our payers to continuously improve value across our whole population. So some of you in the room who are part of medical groups that have some form of capitation, professional services, whatever the scope may be, you've had a little bit of taste of it, but it hasn't, for most groups, it's not been a stay in business issue, with the exception of the groups that only take global cap. They've gotten into this mindset, and they not surprisingly tend to innovate a little bit faster. So we know that achieving this 2.5 percentage point gain, which is what you have to do in efficiency every year to solve the problem of the woman in the upper left, is not that easy to do. At least it wasn't the first year, and hopefully there'll be some more momentum gained as the experience increases. So that's going to be. I mean, for the rest of your careers, unless you switch to some health system that's not under any pressure, this is going to be your job, is to essentially let's figure out every year what we're going to do to tweak how we deliver care to get more with less. But once I got into medicine, I got very interested in what's called positive outlier research, where essentially you look at a distribution of health systems on some measure of quality and total cost of care, and then you actually go and look and see what's happening among those health systems that are in the what's called at the efficiency frontier. That is, they appear to be getting higher quality scores or more health with less total health insurance fuel burn. You can do this for hospitals, you can do it for medical groups, you can do it for any unit of analysis. But this is so for the first 10 years that the IHA P4P program ran in California, I was chosen to be the chair of the steering committee, and I just kept saying, I want us to measure total cost of care, risk adjusted, and quality. And I just couldn't wait, for the first, report to come out. And I said, I want it laid out just like this on this grid. And I want each dot to represent one of the medical groups, one of the 220 medical groups that participates in the P4P program. And I just want to see, what the distribution looks like. And I'm particularly interested in understanding what's going on among the so-called positive value outliers. These are the ones who, the way to think about this is the vertical axis is the composite IHA quality score, including patient experience and all the HEDIS measures and everything under the sun that the medical groups wanted to be measured on. And then the horizontal axis is for your commercial HMO population in California, your total health insurance fuel burn per person per year. So you can see that, that if you compare those at the so-called value frontier, the positive value outliers, with the middle of the distribution, it represents, as the IOM has been saying for years now, about a 30% opportunity to reduce per capita spending and a substantial opportunity to improve quality as well. So that's think of that as the static improvement opportunities. That is, if we simply better understood what's happening up there, and then to the degree it was possible, transplanted those ideas, into our own delivery systems, we should be able to get somewhere between 0 and 30% gain, depending on our baseline state. And in any industry, the general term for this is translational efficiency. You're translating what your most able competitors are doing and transplanting them into what you do. And IOCP, as you can think about it, that's really we're a giant group exercise in translational efficiency. We're taking something that was sort of emerged out of a combination of a design effort that the California Healthcare Foundation funded around 2005. That was sort of one source of the idea. First, these groups found ways of economically intensifying care for the most unstable patient quintile. Idea number two was to curb valueless practice pattern variation, primarily by focusing on who the primary care doctors were referring to for specialist care. Whereas you can either curb variation in terms of if you're an organized medical group, you can work with your outliers, particularly your medical specialist outliers. Or if you have the political ability, you can just be very discreet as to where you send your referrals. You can send them to the positive outliers within the different subspecialty practices, and that's one way of curbing valueless practice variation. And then the last thing we saw in these practices when we studied them, the ones that were really excelling in Medicare Advantage, was simplifying and downshifting discrete tasks that count. You can sort of see how this correlates with IOCP, different features of IOCP. The first is self-evident. The second, I know for some of you it's not politically possible to pick and choose among the specialists in your groups, but those of you who can have a second engine for improving value. And lastly, for those of you that are using care coaches and beginning to build out team care with less expensive people, that perfectly illustrates this idea of simplifying and downshifting discrete tasks. Yes, a doctor can do motivational interviewing and then on an ongoing basis coach the patient, but is that the right pay level for that job on an ongoing basis? I don't think so. So we did that, but notice I have a parentheses here, features differ for privately insureds. This would make sense, right? If you're talking about patients between 18 and 65, the features of the positive outliers might look a little different. And I've shown you a little clip from American Idol because I was dying, once I did the MA study, or the Medicare study, I was dying to do one for the commercial population. And so I persuaded a foundation to fund it when I came to Stanford. And so we're just about done with the first phase of what we call our American Idol in Medicine study. But I did the same thing I just repeated for IHA on a national basis. I repeated what I'd done for IHA, with the IHA data on a national basis. And I got a hold of a gigantic American health insurance claims database over several years. And we looked at 3 units of analysis. First were primary care practices. Second was community hospitals. And the third was, we're about to do 7 medical subspecialties. And for each of them, we have a diagram just like the one I showed you a minute ago, where we calculate total cost of care attributed to the doctors who are managing the patients, using the same kind of attribution algorithms that you're more than familiar with. And then we looked at available data on quality, and then looked at those that were in the top quintile on both, and then sent teams, people like you who have experience in trying to manage care, onto the sites to basically say, is there anything different going on here, or anything that impresses us as distinctive? And then to do the same thing for a sample of sites from the middle of the distribution, and then subtract the two, and see what appears to be associated with much lower cost and much higher quality at each of those 3 units of analysis. The primary care study is almost wrapped up, and though the foundation is going to release it, we're not going to release it. That's our agreement with them. But at least I have been able to show it to a few people whose judgment I just tremendously trust. I showed it, for example, to your leaders, Alan and Ann. And I can't tell you how relieved I was when Alan and somebody else who was there, Tom Bodenheimer, who I trust, said, "This makes total sense. This is the IOCP equivalent for as it were for the under 65 population." So I look forward to sharing that with you as soon as we're authorized to release it. Really focus on people who are 30 years old plus or minus 3. And these tend to be people who got master's or doctoral degrees in different disciplines. Could be medicine, nursing, engineering, social science. We tried to mix it up. And then we surround them with seasoned mentors, because there is a problem when inexperienced people purely brainstorm. You can get some ideas that aren't too great. Brainstorming has got some problems too. And so we essentially did so that we rely on these younger people to come up with extreme ideas, and then we ask people my age from diverse disciplines to sort of comment, ask questions, ask the fellows to go call this person or that person, no matter where they are. And in the end, what happens is they end up doing a global search of the most cost-effective ways of providing care for whatever their target is for the year. And then they end up taking ideas from here and there and forming composites that really constitute a new life form of care delivery when you add it all up. And so we do our best to help them find exemplars around the world that are at the frontier of low cost and high quality. So for this, for example, this year, one of the teams was focused on coming up with a much more cost-effective approach to ambulatory surgery care. And so we sent the teams to spend 2 weeks in Bangalore. And there's a hospital that's producing coronary bypass graft surgeries for about $1,200 each, all in. And obviously, a lot of that is due to lower labor costs and lower non-labor input costs. But what we did is we teamed up with Harvard Business School, and we're doing what's called an activity-based costing analysis of that hospital versus another hospital that's believed to be among the most efficient, high quality in America, Intermountain Hospital, plus one of these so-called focus factories, which is the Baylor Heart Hospital in Dallas. And what we're going to do is we're going to neutralize, we're taking each of the methods by which each hospital produces a bypass graft surgery, and we're going to input the same prices for labor and non-labor inputs and see which one has the most efficient, quote-unquote, manufacturing process. That's called an activity-based costing study. So we do that. We expose them to the global friend to get value, and they get ideas from all over the world doing this. And then we also say, and this is, again, idea I have to credit David Kelly with. He said, listen, no matter how cost-effective or how valuable your innovation is, if it doesn't embed features that address the most fundamental unmet needs of people with regard to current care, it's unlikely to go anywhere, particularly in an industry that's not historically been subject to a lot of value pressure like the health industry. And so we have the fellows spend more time than they want to just asking a lot of patients and clinicians providing the kind of care that they're studying, what is it that absolutely disgusts you about current care? And then that's how we sort of elicit deeply felt unmet needs. And then we try to make sure in the new innovation that we come up with that we've done something to address those most frequently mentioned unmet needs. And then in the end, I keep saying to the fellows over and over again, your job is to do one of two things. You either have to prevent strategically. By prevent strategically meaning you don't say, oh, here's an opportunity to prevent, let's invest resources. I said to them, remember the Western movies when, either the good guys or the bad guys, they always would try to find the right ambush point, for ambushing whoever it was they were trying to ambush. I said, that's the metaphor I want you to use, because as you think about the evolution of an illness, there are certain points where your available intervention tools are going to be a lot more cost effective when applied than at a different point in the evolution of an illness. And I said, if you want to save money, you've got to start picking your intervention points very strategically, taking into account likely impact. And then after you've done everything you can to prevent strategically, then I said you have to figure out how to produce efficiently. And that's why I sent them to India, because they weren't preventing anything. They simply were, when people actually needed a bypass graft surgery, they were producing it extremely efficiently. That's the job. If you're interested in actually coming up with new ideas, it's at least a mental model for you to work with. Here is the results. Here in very high level, we had one group, we assigned them last year, the year before last. We said, come up with a much more cost-effective model for preventing and treating strokes. So they applied these things, and in the end, what came out were these three primary features. And these are the kind of things that particularly an entity like IOCP system could actually take on, because there's nothing in here until you get to the inpatient components that an IOCP program couldn't assure. But the three things, when they said, listen, if you want to prevent and treat strokes much more efficiently, here are the three levers. The first is, if you can control blood pressure, you can do a lot to prevent strokes, and plus you get an MI prevention dividend at the same time. And they said the fact is that the average percentage of patients with hypertension who are in good control in the United States is about 65%, 70% maybe. And yet there are exemplars in the US that are closing in on 90%, right here, Permanente, Northern California. And so what they did is they studied what Permanente and the others getting 90% were doing. Then they said, we think you can do it even less expensively, because we don't think, since 2/3 of the reasons people don't take their meds are not for medical reasons, why would you use expensive nurses to do it? Why can't you use, for the non-medical reasons, less expensive people? And so they came up with a model that they think will be even more cost effective than Permanentes, but not be any less effective. Second thing they noticed is that when patients have mild strokes or they have a TIA, so by the time they get to the ER, the symptoms are already gone. If you actually looked at the literature on this, it would suggest that as long as there's someone who's sentient and has capability at home to watch the person, most of these patients can get what workup they need in less than 23 hours, and then go home and then get the rest of their workup without staying in the hospital. Right now, most of these patients with mild strokes and TIAs are kept in the hospital for 2 or 3 or 4 days, and depending on how much you're being charged for hospitalization, but it's well into the teens in terms of prevented bill. So that's the second thing that they culled out of the global literature in their own imagination. And the third thing they found is the TPA administration is like, wow, would we have an opportunity in this country? This is, I realize, out of the IOCP kind of range, but just to give you a sense of what it is, as soon as the fellows explained this to me, I just said, this is really important. Would anybody want to take a guess at what the average door-to-needle time is for patients who come in with what turns out to be an ischemic stroke before they get their clot buster? Assuming that they're within the 4.5-hour range, that it makes a difference. 90 minutes, 2 hours. Well, it's actually not that bad. It's about, last time it was measured, and by the way, this is just, you may be right, because this was just measured for the Get With The Guidelines, hospitals, but it was about 70 minutes. Would you like to know what a systematic redesign of this process has achieved in places like Finland and Australia and St. Louis and Calgary? 17 minutes. So run the math. 70 minutes minus 17 is 53 minutes. Here's something else I learned from the fellows. Would you like to know what the current neurologic research suggests is the average number of brain cell deaths per minute delay between that in that interval? About 2 million. So think of it as for every stroke patient that comes in with a stroke that is gauged at a severity of 5 or above, it's an opportunity to prevent the deaths of about 100 million brain cells simply by assuring this approach. And the approach is very cool. I mean, it involves things like simple things that aren't expensive, but they just have huge leverage, like connecting the ambulance crew with a stroke neurologist, wherever they may be, and having the stroke neurologist piece together the story, talking to the ambulance drivers, the patient's family member that's usually in the ambulance, and deciding whether or not it's sufficiently certain that this is stroke, that they bypass the ER. They say, forget the ER, that's a waste of time. What the patients are going to need is a CT scan to figure out whether it's hemorrhagic or ischemic. You need to know that before you administer the TPA. And then they said there's also a problem with a lot of emergency room doctors have been traumatized because they've injected TPA and had a patient stroke out, die right in front of them. And so even though the evidence-based guideline says you give it anyway, there's a risk, but the benefit is far exceeding the risk, a lot of them don't give it. And so in Calgary, what they do is they are not willing to trust the ER docs. They page the neurology nurse down from the neurology unit with TPA ready to inject, and assuming that the patient consent or the patient's family's consent is obtained, as soon as the CT scan is read, whambo, that's how it works. And so the substantial number of disabling strokes prevented as a consequence. You get a sense of what goes on when you're trying to create one of these composites. So one of the things that you begin to do is you listen to what the fellows are discovering from these global searches for high value. It begins to give you a hint as what might be coming in innovation in medicine. I thought I'd just share that with you because I think it's good. It'd be fun to talk about. First, I see this evolution in content, and for this, I really have to give credit to Alan Glasseroff. He's really, it's so fabulous to see what he's done. So we had this, we actually, the IOCP model was actually Boeing's name for the AICU model. That was what the foundation funded us to develop, and it was really Alan who said, I see ways of improving on this, and one idea was, because a sick patient's risk of getting into trouble doesn't just depend on on a perfect H&P, you got to take into account these other forces, like the nature of the ordinary healthcare system that's around the patient, absent the IOCP. What is its propensities and capabilities and weaknesses? You got to take into account what's going on with the family. As Alan has taught me, you also need to get a sense of the patient's sense of confidence to do anything you ask them to do, the so-called PAM survey. But it's and behavioral health. It's basically being to realize if you want to take fundamentally medically unstable patients and keep them out of trouble, you can't narrowly focus on the H&P findings. You got to look at these other axes and then come up with both an assessment and a plan that takes into account these axes. And that's really an insight that I've increasingly appreciated, that really I credit Alan and Ann with developing. But it's a great illustration. The second thing I see happening at the margin is you see some health systems that are just like totally excited about lean, right? And so and they say, and I'm on one of the boards of one of these organizations that's spreading it nationally, and they say, well, the key thing is this is culture. You got to establish a culture where people are constantly looking at what they're doing and trying to find ways of removing stuff that are wasteful. That's my very gross simplification of lean. But you see other health systems that are getting great results, especially on quality, by emphasizing a culture of reliability. And then others, and I wrote about this in my Medicare Advantage outlier study, that are getting a lot of mileage out of a culture in which the patients genuinely feel that the practice or the health system cares about them. Those are all three. I think you'll start to see an emphasis on all three facets of cultural change within healthcare organizations for those that are really at the top of their game. And increasingly now, I think we're going to see medicine shift into, particularly as it's more accountable for cost and quality, into a kind of a three-layer control system. We have one layer that is the brain layer, and that's the people who get the advantage of being able to stand back from the front line and observe what's going on a simultaneous basis, particularly for patients that are unstable, and can say to their peers who are at the front lines, this thing that we intend to happen is not happening. We should do something about it. Then there's I referred to the brawn layer. That's what I used to do in medicine. I did everything. I was at the front line, right? I was like talking to the patients, and I was examining them. That will still be, that'll be the mainstream of what patients experience, but it's a different layer. And then there's the bits layer, meaning that both the brawn layer and the brain layer will be increasingly supported with information systems that'll give them clues about either opportunities to change the treatment plan, so-called clinical decision support, or to actually change, to step in because what is intended to happen is not happening. Think of that as clinical workflow support systems. That's where I think we're headed. Now, and I've shown obviously an air traffic control tower because air pilots figured this out a long time ago. They basically said, when you get around an airport, there's a lot happening. And you're trying to fly the plane and you're trying to watch for other planes, and it's just a little bit of a cognitive overload for even the best pilots. And so they developed this brain layer that only operates during this moment of high risk, is during the takeoff and landing, when there's a lot of other planes in the area. Well, I said, listen, if this is such a great idea, there must be examples of where this has really made a difference. And so I began searching, and indeed, there is a great source of information. An independent researcher from UMass Medical Center in CHEST, just last month, studied what happened in 56 different ICUs from all, very diverse environments, all over the United States, that use this kind of a control system, where you have a brain layer deliberately removed from the front line and supplementing the front line. And the way to look at this is that this is, by the way, this is the impact on mortality, but the results on length of stay, which is your cost variable, was virtually identical. And the left-hand column, the dotted line shows if you're on the dotted line, it means that ICU took this system, and it neither improved nor impaired results in terms of risk-adjusted mortality. The left side is ICU mortality, and just to keep themselves honest, the right side represents hospital mortalities. And if you're on the left side of the dotted line, it means your ratio of actual deaths to expected deaths based on how sick the patients were when they came in is favorable. And the right-hand side of the dotted line means you actually took this great idea and made things worse. And what's cool about this is it shows that obviously the central tendency was very positive. If you look at this death rate, this is by the this is published by Craig Lilly in Chest last month, if you're interested. But basically, I'm close enough to read it. But the average reduction in risk-adjusted death rate across the whole group, including those that messed up, was down 26%. It lasted. They got about a 15% reduction in ICU mortality. The length of stay reduction, which pretty well tracks with cost per stay, went down about 15 to 18%. So it was a really great double win, and I think confirmation that this is a good idea. Human brains are fabulous, and they can do things that they can do some things that machines won't come close to replicating for a while. But one of the things it turns out brains don't do well is last very long in terms of their ability to think really sharply. And so when you get into a high-stakes clinical situation, it turns out that your ability to think as smartly as you could have, when you first started your shift, begins to deteriorate. And what's really interesting is it deteriorates and you don't realize it's deteriorating. You still think you know what you're doing. And the most dramatic proof of this came from a study that was just published last year, which is it is really cool in terms of explaining why control systems are needed and why they work so well, for example, in ICU care. And they may even work in IOCP. I don't know. I'll leave that to you and Alan and Ann to figure out. I just wanted to close with a thank you. Obviously we're at this point where everybody's talking about accountability for value, but in truth, a lot of the risk shifting is yet to come. So a lot of you are in situations where if your IOCP program succeeds, you will actually be doing some financial damage in some cases to your delivery systems. And so it is a tough time to be doing this. The future belongs to people like you, who are learning how to both translate, borrow cost-effective ideas from other systems and make them work quickly and successfully, and those of you who get interested in inventing new ways of delivering care. IOCP project, you're going to be learning the skills that will be hugely important to not just to your delivery system, but frankly, to the future of the prosperity of the United States.
In a lot of ways, this is a carryover to both Lisa's presentation, which was, you saw the two graphs about we're recruiting here and we wanted it to be there. And then also what Arnie just had to talk about in terms of what the overall job is about. And then rather than just focus on how do you better recruit, because we will be talking about how to better recruit. We're going to be also talking about what are all the audiences you need to be recruiting from, which are not just the patients that you're trying to enroll in the program, right? Our work, which is it's a program. Ann and I were brought to Stanford by Arnie. We have two programs just to start out for people that haven't met us before. One of them is an intensivist model where there's actually a clinic and all of the physicians, two of which are Ann and I, and there's a third, do the primary care of the top 10% of the patients. And we're working with people that are largely employees or dependents of Stanford. And we also do a distributed model, which is what more of you are doing, where we're help co-manage patients or support patients that are getting care elsewhere within the Stanford delivery system, getting their primary care elsewhere. And but the issues around recruiting, though some of the messaging is different, are much the same. And in the long run, this is about how do you survive as a disruptive innovation within an institution. So at Stanford, there are 300 patients in our program right now, and that's the only capitation at Stanford, right? So it's not an atmosphere where everybody's on board with the new agenda. We just last week met with an organization. Arnie showed you number 24 on the Medicare Pioneer data on that slide. They were the one who started as the cheapest, and they actually saved the most money, percentage-wise. And and you go, what an amazing organization. Well, that organization visited us last week to learn our model, and because they're not, they want to do even more with primary care redesign than they're already doing. And it was really interesting talking to them, because they're doing what they're doing with only 5% of their business at risk, which I think is pretty tremendous. They have very visionary leadership is what the difference is. They're much like a lot of delegated groups in California. They have a hospital. They bought up a bunch of practices across the state of Wisconsin. They're based out of Green Bay. It's called Bellin Health is the name of the organization. There were a lot of similarities with what they're doing and what a lot of the organizations are doing in California. So let me launch here. Nobody said this was going to be easy to do what we're doing. And Arnie kind of just, I think, did a really tremendous job of describing why it's important that we do what we do. Lisa did a really good job turning the heat up of do it faster, better, leaner, right? And then how do you live with the tension of those two things? So what we're going to talk about is what you do with 4 different audiences that you need to recruit from, either recruit resources or recruit people, in order to succeed at this. And success is not nailing IOCP through the end of the grant. Success is having a sustainable program that you can keep going forward with. Right? One is the payer, the plan on the hook for the spend of these patients. And in IOCP, it's Medicare. And that's actually a pretty hard customer to work with, because they don't really come down to the ground and talk to us very often. Number 2 is the organization for whom you work for, of which you are a weird, aberrant program in something that's still largely dedicated to heads and beds. The third one is the medical peers that you're working with, where you have to actually get them to support your program, or at least be neutral and not antagonistic. Though support is definitely the way to go if you can pull it off, because you want them to refer you patients and work with you. And then the fourth one is the patients you seek to enroll, right, and recruiting them. So we're going to cover all of those 4. You ignore any of them, you're probably set up for non-sustainability. You may succeed for the grant, but you won't sustain when this is over unless you've done all of these 4 things. First is marketing to health plans and self-funded employers. As you negotiate rates for what you need to sustain a viable program, and try to do it as lean as you can possibly do it. At Stanford, we had to go to HR and to the CFO of Stanford Hospital and the CFO of Stanford University, which is way bigger than Stanford Hospital, and say, we need X amount of dollars per month to manage this population. And we developed that number, and we did it 2 different ways. We looked at the annual spend of patients in the current in the current system without us, which totaled $88,000 a year average patient in the high-risk category. And then we built the team that we thought we needed from the ground up, and looked at salaries and indirect compensation and all the ways that we're being charged. And we came together with those 2 numbers, assuming a certain savings, and said, this is what we need as cap, which was, if you look at the average PCP cap, is about 20 times. But you're going there and giving this outrageous fee that you need to be supported, and they're going, what? What are you talking about? So this is what you do. So the average cost of the patients without you is a really important number, the total spend. And if you assume 10% savings, IOCP actually promised Medicare 5% savings, but if let's say you say 10% savings, what is 10% of 88,000? It was what we were talking about at Stanford. So that's $8,000, right? And what we did was price our intervention at about $3,000 per patient. And therefore, there's, we're hoping, we also arranged a shared savings arrangement for the other, to get into the other 5,000 as well. They may also be asking you to take on patients that are big losers for the hospital, right? And those are often either underinsured or uninsured that are in the ER or the hospital all the time. Turns out to be largely very different work than the work we're talking about here. And you're basically a transition clinic then, and not that it's bad to be a transitions clinic, but if you really want to know what to do for that piece of the work, the other talk going on at the same time is better because it's talking about the lives of people in that category. But you need can the hospital tell you what's their lost opportunity cost by having these uninsured or badly insured patients in the hospital and they're a loser, and freeing up the beds for better paying customers, what's that worth to them? Because then you can begin to say, well, what's at stake and how do I position myself within that or our program? Then it's about modeling what would 10% savings mean, what would 20% savings mean, what would 30% savings mean, and how much money is that? And then you need to be somewhere in there. If you're over that in your setup, no way it's going to work, right? But if you're less than it and significantly less than it, then if we're able to save $8,000 a patient and we cost $3,000 a patient to do the intervention, that leaves $5,000 to, that goes back to the institution. They like that. That's good math. I just met with the Stanford CFO and showed him that data this week because our early returns are very promising in this regard. We're in the 30% savings range gross and 20% savings net. They like that, and he really perked up when he heard those numbers. The model we came up with was capitation with shared savings. Then the job is who are the patients and what are their issues, and it's really good to be able to talk about that with the insurer. This is what we're actually trying to do so that they care about the project outside of just the dollars. Staffing, you staff as lean as you possibly can with the measure you're looking at being the most touches you can have on a patient. So we're measuring touches per patient. You guys are submitting data to Milliman around that right now, and I haven't seen the data. Rob is, I think, working on it. And when it comes out, it'll be really exciting. We think we're not exactly sure because we have to pull it out of a lot of sources, and we lost our data analysts for a while. We're about to get them back. But we think we're in the 60 touches a year range per patient, 5 touches a month per patient. And touch defined as a visit, a two-way phone call, or an email that drew a response, right? And then going to your own C-suite about this and saying, look, we know we won't be sustainable if we're spending too much money in our intervention, but trust us don't micromanage how we spend the money. Let us have the freedom to do it. And that's pretty hard to do because you don't get to be COO or CFO by not micromanaging generally, right? So the very behavior of the people we're asking to work with us is counter to, why don't you go over in a corner and innovate, and then in a year we'll see how you're doing, right? That's not how most organizations act. And then you got to schedule lots of frequent one-on-one updates with the people that you've been talking to from the payer role. And the payer role, if it's the hospital as payer, then you talk to them. And if it's the health plan as payer, you talk to them and give updates on progress and tell them success stories and thank them profusely. And because you can't just assume people that you're not in contact with are going to be thinking right thoughts about you, right? You need to constantly follow up. All right, let me step aside now and hand off to Ann.
Okay, so here, this follows from what Arnie said, about the people you work for. And this isn't the payers in this case, but it's the people who, you know, pay the payrolls of your staff. And we're all stuck in institutions and a whole medical trend where RVUs, or, you know, billable services, are dominant. And if you remember that slide that Arnie had with the 4 or 5 circles going up, we're disruptive, we're an innovation, and we're the future, I think, is where, you know, care costs are going to be managed care is more, you know, we're moving to ACOs, all of us. And so but we're living in this contradictory period of we're neither here nor there, because what we do isn't strictly, you know, it might cost RVUs to the institution. But there are other things that you can look at, and one is certainly patient satisfaction and value, or something that we're going to be increasingly responsible for reporting to payers. And this is the way you do it. And one way of, then you need also to see what the panel size is. And if we're dealing with high-risk patients, it really can't take care of as many. And we have the DXCG, or the risk score, and for our patients, it's probably about 9 in our primary care practice. So we figure we need 9 times as many staff, or our ratio to service would be 1/9 of what it is. So for a physician in our practice, we figure that's about 250 patients. And for our care coordinators who are medical assistants, we say it's 100. And it's also in our institutions. You know, the primary care is struggling to get more resources to, you know, because they're trying to figure out teamwork as well. And I think that we are the harbinger of we can show people how to work in teams, how to, you know, take care of high-risk patients, and we can actually help the institutions with their primary care. We don't really know, in terms of the distributive model, what's a good panel size. And if you're talking to your institution about it, you might look at it, because it's actually takes into account people's risk, which is data that you have. Explain why it takes more staff than they might be used to hiring to take care of those people to really get the value out of it. But where we're moving towards is patient-centered care, and then it makes a lot more difference to be, a lot more sense to be really realistic about what you can do and do a good job. And as Alan, I think you mentioned that in our program, we had the institution didn't think we needed as many people as we thought we needed to do the work with the care support. And we ended up having people burn out and have overtime, and the patients noticed. And when we looked at it on the global way, we said, we need another person. And sure enough, we finally got through and got the other person. People were happier at work, they were doing a better job, the overtime went away, and patients, you know, we could feel that things were going better with patients again. So it's another, those of you who are managers of your program, it's good to keep on your radar the pulse of your staff.
So right, and what we have is 100 for people that are called care coordinators. They're medical assistants trained up.
But in our distributed program, somewhere between about 125 patients. But again, that depends on the severity of the patients. And I think that that's something to assign a number. And where in your organization, the patients may have lower average risk score, or maybe one nurse or one care support person has a panel of high risk people, then you really have to, if you can get that kind of data, it really benefits you and your institution and the people working with you to look at it and try to adjust the panel size accordingly. But there is that risk calculator on the box, that IOCP box, which I think is an interesting, you know, and other people, if they have formulas, should put them on there so we can all learn from them.
You need a dashboard of, you know, how are we doing on quality, how are we doing on patient experience, how are we doing in terms of overtime, how are we doing with staff morale, you know, and be able to look at all that and monitor it and do it. It's almost like active daily management, which is a concept in Lean. And you basically, when it starts falling off, something's wrong. We came to you in the beginning of this project with ratios, But we don't know that they're right for your organizations and the patients you're seeing, right? Only you can know that, but only if you're paying attention. You need the dashboard.
And the institutions may hold you to the ratios that you said initially, and you may find the different numbers better. And so you've got to, if you go with all that information, you're better prepared to say, we can't do a good job unless we have this staff. In order to get physicians to buy in, and in this distributed model, it's to refer patients, to share patients, to be open, to be your team, being part of having you be part of their team for care. You really have to do that along with the patient recruitment. We're here to help you with the patients who you worry about the most and who you never have enough time to really do a good job. And when we presented that to some general medical disciplines at Stanford, and the nurse and the social worker who do our distributed program, the reaction of the doctors was, you guys are angels. It's probably better to go talk to providers, and it may be nurse practitioners or PAs or doctors who might refer to you or might share patients with you. Better to talk to them individually, because that you can, sometimes if you get in a wolf pack of providers and one of them's unhappy, that can sway the whole group against you. Unless you can plant some people who we know are really strong and talk to them ahead of time and who are respected by their colleagues, it's potentially a dangerous thing to do it in groups, although it's tempting. And so you can often get a sense ahead of time from the pre-work you've done that who are the people might give you trouble and who are the people who can really support you. That if it helps to approach providers with a list of patients who, because of your work with the risk stratification claims and looking at who's been in the emergency room, who's been admitted, these people are people who we think might be good it might benefit. These are your patients who we think you might need extra help with. And they might benefit, patients might benefit from the program and from our support. And are there other people? Are these the right people? Are there other people we're missing? And that actually the scores, the risk scores, are only 30% accurate at the top 10%. And there have been studies that show that the physicians or the providers can actually increase the sensitivity of that and really help you get the right patients.
And what I'm going to show is how we started out wrong and then the process we went through to change our approach. And a lot of what we're showing you is sort of particular to our environment, but I'm not showing it to you so you can copy it, though you're welcome to copy it, but rather asking you whether to think about going through the same process that we went through or a similar process. So we found the biggest problem we had talking about our program in one of the more over-doctored, over-specialisted, over-served communities on the face of the earth, which is people working at Stanford University in the midst of the Silicon Valley with the Palo Alto Medical Foundation across the street, right? And both of them, we had patients that were in both camps that were coming to us, and it wasn't for lack of access that they needed our services. This is the absolute opposite of an underserved medical community. But what we found is when we described what we could offer, nobody believed it because it was so far from their current experience getting health care. So I wanted to start, there's a great article written by a guy named Murray Ross, who's at Kaiser, National Kaiser, and he did this brilliant study, and it was done in 2009, that was called From Our Lips to Whose Ears. And he used the terms of managed care and healthcare redesign, and you can see the terms on the left. So medical home, we're all talking about the medical home, right? Turned out patients hated that. They didn't like medical home. They thought nursing home, home health, or end of life kind of connotations. Medical decision support, we like that term. They don't like it. To them, it means end of life decisions, or then you talk about guidelines or treatment guidelines. These are restrictive, rigid, limited, driven by cost, and trying to sort of force the patient into, into somebody's computerized vision of the future. Integrated delivery systems. It's bureaucratic industry language, and the meaning is meaningless to most of the patients we're talking about. Integrated care. Again, unclear, bureaucratic. Multi-specialty medical group. Meaning unclear, trying to do too much, means low quality to different groups. It limits the choice of specialists that they get to choose from. And we're a country right now really confused about the value versus liberty. The politics of the United States are all about liberty right now. Even the liberty to go uninsured is a big issue at the moment in the United States. So liberty actually, if you come in saying, well, we're going to give you all this great stuff, but narrow your choice, Arnie's talking about referring to narrow pools of specialists, not popular at all. And evidence-based medicine, this is like, mother and apple pie and the flag to the medical profession. To patients, it means cookie cutter, impersonal, not about me. And then accountable, just was a thing they didn't understand at all. And it turns out there aren't 1,300 people to recruit there. The risk is not, there are some really sick people, but they're only like 5% of the total population, not 10%, right? The reason I show you is this is what our weekly target is, right? And each one of these is a week, right, or a month, with four bars in between. And the blue is primary care, and the yellow is the distributed model. The blue is the intensivist model. How many times did we reach our target in that thing? Not many, right? That should create what my father would call agita in your teams. You're not hitting your targets. It certainly causes agita to Lisa, right? And she tells me this is what costs her sleep, right? So you should have something like this. And then we thought about from our lips to whose ears, and it turned out almost none of the words we started out using work. So chronic diseases, throw it out. Patients don't like it. Ongoing conditions, much nicer. Ambulatory ICU, which was Arnie's term, throw it out. It's coordinated care. Group visits, don't want to go to a group visit. We're important people. Seminars, we're holding seminars now instead of group visits. People love them, by the way. Care management, I don't want to be managed. I'm not something you have to manage. I want to be supported, so it became care support. My MD, my care coordinator, or my doctor, the doctor saying my care coordinator, here's my nurse, here's my care coordinator became, this is your nurse, your care coordinator to the patients, right? Rephrasing. And then coordinate your care turned into care with you at the center. And then how did we do this? So we hired a woman who was a person who had worked at IDEO, the same firm Arnie talked about in the design stuff, David Kelly and all that he mentioned. And what she did was go out and interview a bunch of people about why they had turned us down, right? And the project goal was to figure insight-based concepts that are visually compelling and communicate why people should sign up, right? What she found out is that what we were selling was way too far-fetched because it sounded way too good to be true. And patients tend to explore their options, but don't commit. And the only time they commit is in the midst of a crisis, which we would love to have prevented. So we had to figure out a way to differentiate what we were doing from what they had experienced before without criticizing. So we changed our logo. Isn't this pretty? The succulent flower with the patient at the center is the idea. That's a model of team care. We came up with a design, 21st century approach to healthcare with you at the center. When we did that, we saw surges of enrollment. Within 2 or 3 weeks, a huge bump in enrollment just by remessaging. We stopped trying to recruit people to the program. We started inviting them to open houses. Come meet the team. Come see the clinic. And then they come, and we, it was rare that we didn't sign up 70–80% of everybody that showed up at an open house. We have a brochure, and pretty, huh? And it says, I'll read it out loud. One thing we've learned about healthcare is that everybody and every body is different. Each of us has different needs, and those needs change over time. Stanford Hospital and Clinics has created a bold new approach to the delivery of customized health services. We offer a patient-centered practice, probably we shouldn't have used that word based on what we heard before, that is oriented towards people who may not be fully served by the existing system, right? We call it Stanford Coordinated Care. It's designed for people whose healthcare needs involve more than an annual checkup or a 15-minute session with a primary care physician, right? And then people say, yeah, I hate that 15-minute visit, and then they suddenly were attracted to us. There's nothing wrong with that model, it just doesn't meet everyone's needs, and that way it isn't that we were criticizing our peers. We described the team, and we strive to make access simple, safe, and seamless. Try us out, and then it talks about how it works. What we've learned about, again, that's just a repeat, but the one on the right is what makes Stanford Coordinated Care so special is that the staff is dedicated to figuring out all the different things that are going on. It's one-stop shopping with an incredibly high level of attention and care. This is really the way healthcare should be. I am seen as a whole person at SCC, and that was a patient comment. And then we talk here, why should I enroll in Stanford Coordinated Care? And we show nice pictures of our team and repeat a lot of the messaging you just heard. We show pictures of who they would be working with rather than just you'll get a care coordinator. Who else is there to help me? So we have a pharmacist, a nurse, a physical therapist, a social worker, 3 happy, smiling doctors, right? We actually take call 24/7 on all our patients. They reach us. They try it once. They call and say, oh, I really did get you. Sorry, I didn't really have much to talk about. And then we only get called when we need to be. We get very few calls, really a good service. We same-day appointments, and we're making good on that, including the woman who said, I need to come in 4 hours earlier, or I'll go to the ER. We really are off, we're not visit-based, so we tend to email and My Health, and over 50% of our email can be handled by other members of the team, doesn't come to the physician. At the rest of Stanford, 80% of the email goes to the physician. So the docs hate the email, right? It's just a burden to them. But for us, because we have a team, it isn't a burden. Specialty care, we talked about managing specialty care. And one of the things we do is upload specialty reports onto My Health, which is the portal. Who should go? And we say it's people with diabetes, people with chronic pain, people with depression, people with multiple conditions, people with problems hard to diagnose, people who know they need to lose weight and can't do it alone. Are you one of those people? And that actually, people go, yeah, I'm in there. And that's why we get them. And then patients had good things to say about it. We captured these things. So we'd say at SCC, it's not about a doctor telling me what to do. It's about what we're going to do together. They give me the confidence to take the drama out of healthcare. As a patient, you don't always know how to communicate with your specialist and tell them what's important. SCC helped me figure out how to ask my specialist the right questions. After joining SCC, life was about growing again. These were all real comments people said to the person from IDEO who went out and captured them. I was opening up. I was moving forward. They encouraged me to go on a vacation despite my health issues. Now I'm looking into getting my master's degree. At SCC, I'm in and out in a half an hour. That's not just great for me, but also for my manager because it's less time out of their seat. We do computer visits with people sitting in their seats at work because Stanford's a place where the non-exempt, the exempt employees, who are not on hourly, often the expectation is 12 hours a day, 6 days a week, right? So leaving work is a really hard time to them. So that's our presentation.
I'm Jan Taubman, and I am the Director for Quality and Care Management at Arizona Care Network. I've been in my role for about 5 months now, and we had started doing care coordination as an organization back in March or April of last year. And we had actually insourced the 3 RN coordinators from Optum, and the intent is to bring them over to ACN at the end of a contract period, which is the end of June. So they'll be transferring over. Everybody that we have hired since then is our employee. It wasn't until I came on that we started to add disciplines to our team. So we had the 3 RNs, and then we added a couple of social workers after the first of the year, and we've hired and have in place what we're calling community resource aides. We actually are budgeted to have 5 ambulatory teams, and those teams will consist of an RN, a half of a social worker, and a minimum of 3 of the CRAs, and 0.3 of a clinical pharmacist. I forgot, we have a half-time clinical pharmacist already on board. So, interestingly enough, I mean, we've had some challenges, of course, one of which has been that the RNs were very used to doing it all for a year, almost. And so it's a learning curve for them to let go and to be able to utilize the licensed clinical social workers, and especially now the CRAs. In fact, at our team meeting the other day, one of the CRAs said, I really think that you all could be tasking more things to us. You could let that go. And we've had some conversation about that. So for example, one of the nurses said, yes, but she said, you know, if I have to make a phone call, it's just one phone call. It doesn't take me very much time to do that. It takes me as much time to task you with the task. But then when we actually talked about it and about the follow-up that needed to happen after the phone call and the tasking of that and whatever, then it was like, yeah, you're right. I should be tasking that and getting that off of my plate. The other challenge that I've had is we have 2 social workers. I need desperately for the 3rd social worker to be Spanish speaking. And I just have not been able to find somebody that fits that bill at this point in time. It was in our earlier session this morning, it was interesting to have the conversation about hiring and the skills of figuring out who is the best person for the job, because we certainly, while I think we've been very lucky, I think that it's been more luck than science. And I'd like for us to be able to get better at doing that. We also have 2 RNs that are what we call post-acute. And so they are specifically focused on patients that are hospitalized and patients that are transitioning to a skilled nursing facility. They follow them while they're in the skilled facility, and then when they are discharged to home, they make that transition with them. If they are going to need significant resources for a longer period of time, they actually do a handoff to the ambulatory team. Otherwise, if it's going to be kind of the maintenance in the IOCP, then they continue to work with that so that there's, with that individual patient, so there's not a lot of extra handoffs. We had no real formal orientation program. So we've kind of been doing this by the seat of our pants and building it as we go along. And I would say that this is not just for the CRAs, but this is for every position that we've hired. We do have job descriptions for all of our positions, and they are very forgiving. They're very loose, and that's that's good. But what we are finding is that, and specifically for the CRAs now, we have developed some guidelines that says this is what the CRA will do, can do, and this is absolutely what they cannot do. So that they have a real clean, clear picture in their head about what would be going out of their scope of practice. And we were talking at one of the breaks, one of the differences for our team is that they're out in the home. They're out there on their own, and we want them to never be in a position where they feel like they're having to overstep and give information that maybe they aren't quite sure about. So we want to have that be real clear about what's okay for them to talk about and what they need to call the RN or the social worker to come in or the pharmacist to come in and step in. Yes. Yes, and several of our CRAs now are Spanish speaking, so that's really good, and we have an RN who is Spanish speaking. We also have done a fair amount of word of mouth, so we have nurses, our nurses or our social workers know somebody who knows somebody, and they have routed people through to us that way. But those are the main two ways that we recruit. Actually, initially, we thought that we would find most of the CRAs from the MA population. And yet we found one person who has had no MA experience, but had worked out in a community center as a referral person. And she knows where to find anything. So after we came in contact with her, we said, wait a second, probably the MA requirement might be too restrictive for us. So anybody who says they're interested, we'll sit down and talk with, because it's often then that you find out the resources. One of our candidates that we hired did have some clinic experience, but the majority of her experience came from taking care of her mother, who became disabled, and she had to work her way. She took care of her until she passed away, and she had to find her way through the Medicaid system and durable DME and problems in the home and all kinds of things. So it was from that one-on-one personal experience that she really worked her way into the position. So we're hoping that by having that discussion with them, having it written down, that if they can't get in touch with them, that they know what it is that they're supposed to do.
I'm Terry Yago. I'm the Director of Medical Services for John Muir Health. We're here in the Bay Area in Walnut Creek. And our teams in our care management department are structured as a team. We have an RN teamed up with an LVN or MPH who we call a healthcare coordinator. And then each team is supported by a disease management assistant. And that person is either an MA or a non-licensed individual who has had a lot of experience in healthcare or in the health insurance market. We have individuals who were unit coordinators who are part of our DMA team. And when we began with the IOCP program, we already had our structure pretty much in place. We had about 800 Medicare patients already enrolled in our case management programs at that time. So we had the RN who was assigned to the high acuity cases, the LVN or healthcare coordinator who took the lower acuity cases. And we soon after that realized that we really did want to focus on utilizing all of our staff to work at the highest level that their license would allow. And they were doing a lot of clerical work. They were doing a lot of coordination that was taking them away from patient time and really addressing the needs of the patient population. So that's when we decided to incorporate the DMA, the Disease Management Assistant position, into the team. And so the DMAs are really focused on supporting their team in reaching out to patients with more routine calls. So for instance, the call to that patient who you know really needs to get to see that specialist, but you think they're going to forget, the DMA makes that call. Reminders to patients on just routine testing that needs to be done. There's a lot of work and preparation that goes into the monthly meetings that our teams have with their assigned primary care physicians, and that's where the DMAs come in. They do a lot of preparation of the patient lists that are going to be brought to those meetings and facilitates the discussion of their patient population so that additional patients can be identified that are amenable to the program. And so that structure has worked really well for us. More recently, over the past 6 months, we've had our senior services team, which is made up of geriatric social workers, join my department. And so we've had the opportunity to integrate them in with our case management programs. And there's not enough of them to actually assign them to each team, but we have processes of coordination in place so that our medical home, our case managers now know that when they have a patient that has a lot of psychosocial issues, especially the geriatric population, they have our senior services team to call on, and we have an actual formal referral process set up in Epic. And it's just a matter of sending that referral with a little bit of background information, and then there's the handoff phone call that occurs, or conversation in person between the case manager and the social worker. And then the social worker can either take point on that case, or the teams can co-manage the patient together. Our case managers, their caseload is up to 125 patients per case manager. That's a nurse case manager. Our healthcare coordinators, currently their caseload is up to 250 patients, but we're finding that that is really challenging for them. That's kind of a lot for them to manage. And I would say probably, I would say 30% of the overall patients that the team is managing are the high acuity cases on average. So it was really a matter of our wanting to get our caseload numbers up. And we were looking at the teams, the RNs and the LVNs, and evaluating, okay, what is the work they're doing every day, and just kind of worked with them and walking through their processes. We were really looking for what are the barriers to reaching out to new patients, identifying those that are appropriate, and getting them engaged in the programs. And it basically just came down to we had to free up their time to be able to do that. And so working on filing, or the various reports that have to be done, we knew that they didn't need to be doing that level of work. So pulling in the clerical support just made a lot of sense. We were developing our case management, our medical home program. One of the things that we really wrote into this program was a formal orientation process for the practices. So we would meet with the primary care physician and the MAs as we were engaging that practice into our case management programs. And one of the key points that we made was the case managers to become part of the primary care team. And the goal really is for the primary care physician to help identify those patients that are appropriate for our programs, and that the PCP really takes a strong role in engaging the patient and referring the patient to his care coordinator. So that to the patient, it appears that the case management team is part of the primary care practice. And that we found was a really important aspect of engaging, our success in engaging patients, getting the PCP's involvement. First of all, we try to identify the patient as working with the RN case manager or working with a healthcare coordinator based on their acuity. However, we have found that there are many patients who are transitioning from the inpatient setting who are going to be highly acute for a period of time, and then they get more stable and can then be passed on to the healthcare coordinator. And when that happens, it's the same concept. We relay it to the patient as, we're all part of the same team. This is my partner that I'm passing you on to. I'm still available for you. We work very closely together. But it's really that communication that this is really a team that you're working with, not just one individual. And I just want to clarify that the disease management assistants, they don't have a patient assignment. So they're not assigned a panel of patients. They're really there to support the entire panel and the team. Yeah.
Do you have any kind of a weekly or routine case conference or care conference?
We have a few different models. We have weekly case conferences with the case management team. Mm-hmm. And that's where the team comes together and our social workers join us from time to time. And we discuss difficult cases, really challenging cases, and everybody, has great feedback and solutions that we all learn from. And then on a monthly basis, each case management team meets with their assigned primary care physicians. And it's the same situation. They're really meant to discuss their patient population, who are new patients that we need to be opening, and then it gives an opportunity for the case manager to discuss with the PCP any challenges they're having with existing patients. Our goal really is to get patients to a point of stability that they can transfer on independently and be supported with community resources. But we're always available for those patients. We have a DMA assigned to each team. So we have an RN, an LVN, and a DMA, all as part of one team. And the way our teams are formatted, we kind of have two models. We have 4 teams that are embedded in larger primary care physicians, and then we have what we call our central medical home, where we have 3 teams that are assigned to the smaller practices throughout the community. It doesn't make sense to really place a team there. And so it's a lot easier to accomplish what you're just referring to for those teams that are embedded in the practices. But for our central medical home teams, when they reach out to the patients, they do that very thing. They relay to the patient that they're part of Dr. Smith's team, and they're calling on his behalf. He asked that the care coordinators become involved, and it really paves the way to opening up that relationship.
I'm Anne Marie Molyneux, and I'm the manager for outpatient services at Brown & Tolan Physicians, which is in San Francisco, and we're an IPA. We do IOCP a little bit differently. We are part of one of the 32 members of the Pioneer ACO project, and we have 20,000 members that are aligned with us through that project, and those are the members we've chosen to do the IOCP intervention on. So what we have for that is we have one nurse who's dedicated to IOCP, and then 2 other nurses that help as well, and then we have 1 care coordinator who's dedicated to IOCP. A lot of the stuff that Jan said I was actually looking at some notes, and we had a lot of those same problems at the beginning. The nurses did not want to, they didn't want to delegate. The care coordinator, they was left doing kind of a boring, not a very interesting job. And over the last year, that has really changed a lot. Our care coordinator, who's an unlicensed woman, and she is absolutely the cornerstone of this project. And the nurse and the care coordinator work very closely together. The patients understand that there's levels of acuity for their needs. If they need to be speaking to a nurse about something, they will get their nurse. If it's something, a DME issue or appointment or a simpler thing, they're very comfortable talking with the care coordinator. Conversely, the physicians are also very comfortable with those roles. And it didn't happen overnight, it's happened over time. But now I feel like we really do have a good team and a good efficient system going on. One of the big things that we've done is we've constantly tweaked our medical record system. to allow for the IOCP process, so how we've set up our assessments, how we've set up our interventions, and it's also, we have a tasking system. So again, with the delegating of the tasks, it was easy to, once you have a task capacity, it was sort of easy to point out which tasks are appropriate to go to the care coordinators and which tasks really need to remain with the RNs. The other thing we've done more so recently is we've included a social worker into our IOCP intervention, and that has been a fabulous addition to the intervention.
LCSW?
Yes,
Okay.
LCSW. And we have many of our IOCP patients see almost interact almost only with the LCSW because the needs they have are mostly, familial or behavioral or support, those sort of things. I was talking to one of our LCSWs recently about MedRec, and she's new to our program, and she could do MedRec. I mean, she said, I do not need to know. I don't need to know the pharmacology behind it. I just need to read the bottle and see what's on it. So the RN would review it, but she's very capable of doing the actual MedRec itself.
She has been such a wonderful addition to our team. And mainly it's around the issues that come up with polypharmacy. So, the patient comes in with the bag,
Yeah.
and when she reviews that with the patient and figures out that they have 3 competing medications, or they're taking 2 of the same thing with a different name, she's able to sometimes whittle down 17 to 25 pills a day that somebody is taking down to 5 or 7. The other thing that's happened is we've had a number of patients who we find out are not taking their medication. And it turns out that it's because they can't afford it. And it's because it's not a generic. So she's been able to find a replacement generic that the patient can get for $4, and the problem is solved. So it's really, we've found a very, very valuable addition to the team. And that's what our pharmacist is doing. She's embedding herself in the high volume practices an afternoon a week, and she goes in and looks for those at-risk patients and reviews their list of meds and makes recommendations.
I actually just wanted to acknowledge Dr. Steve Montemat. Many of you probably know him. He's actually the medical director for the Co-Partner Program, which is our care coordination program. He couldn't be here today. He's seeing one of his daughters graduate. So thank you very much for the introduction and the opportunity. This is what we'll talk about today, sort of what St. Luke's is about, a little bit about our health system, why we're changing, and how do we measure the success in our efforts. And so just a little bit about St. Luke's. We're in Idaho, and our mission is to improve the health of the people in our region. Our vision is to transform healthcare by aligning with physicians and other providers to deliver integrated, seamless, and patient-centered quality care across all of our settings. This is a portion of Idaho. It's a map. It just shows where we are, but we have grown a lot. So we have 6 hospitals, 130 plus clinics, 866 licensed beds, 1,000 aligned physicians. Actually, we have about 650 employed physicians, over 13,000 employees, and we serve about, we do about 1.7 million outpatient visits per year. And we have, as I mentioned, we have several hospitals and clinics. We are a very rural state still, so we have many critical access hospitals and rural health clinics. And the other thing is that you see a lot of little dots in the map there. We have actually grown a lot. I think the St. Luke's of 10 years ago is not the St. Luke's of today. Just like a lot of health systems in the country, we have grown a lot, which leads to a variety of different challenges. We have cultures in our different areas. We have varying EHRs. We have programs that have been in existence already, and we'll talk about how we're putting together some of those programs to create something that is seamless and that actually helps our patients. So this is why we must change. So this is the graph that circulates around St. Luke's a lot. If you ask a lot of the the employees and the managers and just in general people around St. Luke's sort of what the yellow box is. This is what we're talking about. So it just helps us illustrate that we're in this period of time where we're moving from volume-based care to more value-based care. And while we're in that area, the little yellow box, things are going to be very uncomfortable. And I think everybody is sort of probably on the same page, and we all understand that. And the faster we move through that yellow box, the better things will probably be for us. But it is a very difficult transformation. As we move through the yellow box, we'll have more lives covered through value-based care. So being an accountable care organization really helps us in that endeavor. Laws are changing, technology is evolving, the population is getting older and has a lot more needs. They live longer with chronic illnesses, and people need more help. So a few years ago, St. Luke's made this decision to just jump into population health. And so we became an ACO. We are starting to engage a variety of employers and payers to assume more responsibility of patients at a population level, and we just kind of went for it. So, but again, with some of these challenges and the need to move rapidly, it really has been a very interesting experience. I've been with St. Luke's for the last 2.5 years. I've seen a lot of change, and it's been very, very exciting and scary at the same time. But we have to do it. It's very important, so we're doing it. It's going to get more interesting. So IOCP essentially provided, was one of those opportunities to provide more comprehensive, a little bit different type of care for our patients. So, again, I don't have to go in detail into what IOCP is. Everybody here knows what it is. But it is an example of how we have decided to move into more comprehensive care of our patients and deliver care, not in the episodic fashion that we're used to, ED visits, hospitalizations, clinic visits, but really kind of understanding what the overall needs of the patients are, what is actually important to them, and how do we manage the period of time between those episodes of care for our patients, understanding what their needs are and how do we best meet their needs along the continuum of care. This is a busy slide, but it is just an illustration of our care management workflow, just in very general terms, and I'll just walk you through it a little bit. But as we think about our populations, we have to develop strategies for specific segments of the population. I mean, if you think about our population of patients in a pyramid, there are the very complex patients at the tip of the pyramid, and at the bottom of the pyramid, there are the patients who will need as much care. You can segment that pyramid in whatever way you want. Obviously, there are some patients who don't necessarily fit into any of those categories, but it just kind of helps us divide our efforts. As we think about our population health strategy, we are developing strategies to deal with things like complex behavioral health, chronic disease management, wellness, including things like value-based benefit design, and also care management for our most complex patients. So we're at various stages of development in all of those areas, but this is just one portion of it. So how do we deal with some of the most complex patients, medical patients in our system? And so we have entered a few agreements with payers and employers to actually take care of their populations. And we started, two of our populations are actually our Medicare Shared Savings Program population, and also we have a population of Blue Cross patients that we have assumed care for to actually kind of learn how to do these things. So this is where our patients are coming from. So employer contracts, payer contracts, and we're also, we just wanted to put in here that we have other populations in mind that are very high risk, like our self-pay and Medicaid patients. We don't necessarily, there's no payer contract to get the self-pay patients, but we definitely wanted to make sure that we illustrated that we're very concerned about what happens to them. Once we have the populations, we actually put them through this sort of middle area here, which is where we stratify the populations and we identify the patients based on their risk. So to do that, we have point of care information. So for example, you're a primary care doctor, you see a new diabetic in the clinic, very complex. You can kind of stick your head out the door and say, hey, can you, care manager, please help me with this patient? So it's kind of like identification patients or in real time. We also have claims data, and we have information that comes to us from the payers and employers. So and that is actually a big piece of what we'll do. And actually, hopefully we'll have time. I'll show you the analytic tool that we use to get more information on our patients through this analytics tool. And we also do things like health assessments for our own employees, for example, just understanding what their risks are. Then we segment our patients based on their risks. It can be anything from high risk based on predictive modeling, the types of chronic diseases that they have, any complex medical issues that they may have, like trauma or need, like multiple trauma or need for transplant, for example, any social or economic stressors, et cetera, or patients who have just high utilization. You know, they're going to the ED a lot, they're going to the hospital a lot, they're in skilled nursing facilities, rehab, LTAC, et cetera. And then once we identify those patients, they go into our sort of care management area where we triage those patients further, and we sort of do a first pass where we send patients who are going into transitioning from acute settings to post-acute care facilities. We put them through our post-acute care management program, which we launched earlier this year, but also our complex care management program. So patients who are just extremely complex, who need very individualized care, we sort of just take them off the top. And then other patients, we route to other programs, including, for example, our clinic-based care coordination programs. We have specialty care coordination programs. We have post-acute care management at facilities, and we have supporting programs as well that help these other programs, like, for example, palliative care, hospice, et cetera. In terms of the specialty care programs, this is sort of a product of us coming together as a big organization over the last several years. People have figured out how to take care of their sick patients for a very long time. So, you know, if you're a clinic in some small town in Idaho or Oregon, actually, we actually have a clinic in Oregon, people have been figuring out how to take care of these patients for a very long time. You know, people in rural health clinics have been figuring out how to get their own grants to hire people to do this work. Our specialty clinics, like our cancer center or orthopedic centers, they have figured out how to get navigators who can help patients, navigate through these very specific challenges that they have. So part of our work is really not reinventing the wheel, but really figuring out how to align all of these resources that we have throughout our system to actually make sure that we are all speaking the same language, that we can measure the same things, that we can keep track of the same patients, and how do we share patients across these various programs. So that is actually one of the challenges that we have right now that we're working on, but it's very exciting work because everybody really wants to work together. And in terms of the primary care-based care coordination, co-partner is one of our programs, and that is the program that we'll be talking about today, where we are using the IOCP methodology. So that is sort of, in a big, complicated slide, how we're doing things. So at the care management level, these are some of the high-level metrics that we're tracking. And we've split it in the triple aim format. So better health, we're tracking things like readmissions, ED visits, and then each program has its own quality level metrics, including things like, again, hospitalizations, medication reconciliation, smoking, counseling, et cetera. For better care, patient experience, so patient satisfaction with the program, we actually have a process metric for that we're tracking, but each program has its own, they use as sort of a standardized patient satisfaction survey that, and they keep track of their own survey. And actually, Steve will talk about some of those metrics for co-partner later on. And then lower cost, so utilization. We actually track our PMPM for our patients in the care coordination programs. And we use that, again, using the tool that we have developed in conjunction with White Cloud, which is this analytics company based out of Idaho. And so it is, and those are the targets. We would have been happy, we'd be happy if we didn't necessarily want to bend the curve, but if we just kept it flat, that was sort of like our baseline target. And I'll show you sort of how we're doing in that in a little bit later. And then finally, just volume. So how many patients are we actually seeing? Our base target for this very complex population was actually 2% of the patients in a specific population, putting them through our care, some kind of care coordination program, be it co-partner or post-acute care management, complex care management, children's, cancer, whatever. And I'll turn it over to Steve. He'll tell you a little bit about what co-partner is and what it does.
The co-partner program started, Dr. Cadardi introduced it to St. Luke's about 18 months ago from the Boeing model. Our management decided to take that leap of faith because we knew we had to do something different for all the reasons that Dr. Necochea just talked about. So we signed an agreement with Regents to start a care of patients for height risk program. We called it COPAR, care of patients at risk. Luckily, somebody said, well, you don't want to tell your patients you're at risk, and we're going to take care of you. So we relabeled it, rebranded it co-partner, and we've been running with that for a while. But as we grow, one of our lessons that we've learned is how will we get the synthesis of all the other interventions that we're doing now, the care management, the PACM, post-acute care management, transitions of care, congestive heart failures. MISTI is our Mountain States Tumor Institute. That's a different patient population. We also have a huge population of children in our children's hospital that we've all agreed that we can do a better job coordinating their care once they get out of the inpatient setting. So co-partner, we have now, I believe Michelle was giving me an update, we have 4 RNs, 1 position's empty, we have 2 LPNs, and 1 respiratory therapist. And I think we have 1 administrative support to help out. So we started the program. Here's, we have a database that we run, and we're shifting from that database, taking it to the next level. But here's some of the standard information that comes off of the patient engagement results. We have 415 patients. I think yesterday we had 424. So that's a nice little incremental improvement. A recruitment rate is one of our opportunities, and this is appointments with a coordinator. We have approximately 52%, and it depends on which patient populations we're targeting. For example, the Medicaid shared savings patients, they're more willing to listen to us. They're not working the day, they're easier to get a hold of, they'll respond to the calls more frequently, so the recruitment rate for that population is a little bit higher. The enrollment rate, once we get the patients to accept an appointment and we get them in for the super visit, we're looking at probably right around, well, hopefully the rest of you are in that 90% area or more. We have about a 94% retention rate. We were shooting for a target rate of 95, so we're right in that category. That varies. One of our targets was number of patients with care plans. We're a little over our target. Naturally, we'd like to be at 99 or 100%. One of the opportunities we have identified, and I appreciated hearing from the group this morning on the advanced directives discussions. That's really a difficult one. At first, we started measuring, well, do we have advanced directives? And then our steering committee said, well, it's really hard to make sure we have those because we can't be held accountable for those. It's a patient decision. What we can be held accountable for is have we discussed it with them? Yeah, right now it looks like our data is about close to 70%. Our target was 90% discussed. So in terms of just a quick graph on where we were when we started, you can see we started January 13 approximately. We've got a nice steady slope going up. The trend line is increasing. So we did that, and then actually what this dip is, and I'm not 100% certain, but there's a couple factors. One is we were having trouble with our registries. We actually said the well went dry, and we were changing information systems. We'll talk about that as lessons learned. And we actually thought that we were getting patients referred, but they got lost in a database. When we found out what some of the problems were, look how the rates jumped. And I think we're going to start holding steady on that.
This is just to recap our Medicare Shared Savings Program and how we're doing in terms of our recruitment targets for these patients. And that includes all of the care coordination programs, not just co-partner. So this is actually a sampled data, but in terms of better health, I mentioned that one of the things that we're tracking is actually readmissions and hospitalizations, inpatient visits, or ED visits. And this is actually using mock data, but it looks like a straight up just regular graph, but this is actually coming out of the tool that we're using to aggregate our claims data. And by early next week, we should be able to do this for our patient population. So we should be able to tell, for example, a co-partner, how their patients are doing, that they have enrolled in co-partner in terms of inpatient visits, ED, whatever metrics we're measuring there. And same thing with any other care coordination program that has put patients through our program. And also what that actually means in terms of potential savings for them. In terms of lower costs, we are tracking our per member per month amount, so our claims and also the cost. And so this is just a graph. This is actually real data. So it shows for patients in this is a true blue patient population. So this is a Blue Cross patient population that is actually being taken care of by the co-partner team. Sort of what is the change in PMPM over a period of time, and sort of how many claims they put through and over time. So what we do is when they enroll a patient in co-partner, we calculate a baseline for that patient in terms of their PMPM. So we calculate 6 months worth of data prior to their enrollment. And then we track what happens to that patient over a period of time. So this represents 153 members who had been followed by co-partner for 6 months. So we can see what happens to their utilization over time. This is actually the number of claims, and this is their PMPM. And so this looks pretty good, actually. Their PMPM at baseline is actually pretty high. These are patients that we selected because they either had a high risk score or they had 2 or more ED visits or 2 or more inpatient visits potentially. Actually, this probably doesn't reflect so many of those patients. This probably just reflects the high risk patients based on their HCC score. But so it looks pretty good, actually. And if you wanted to do some math, potentially, you could see that this represents almost $100,000, I think, in one of these, probably over here. But so what we're doing right now is actually trying to punch a bunch of holes in this. So we are trying to figure out what is a good control for this data. How can we just go out and say, hey guys, we saved you, $320,000 by doing this program? I don't think we can yet. So that is what we're doing right now. Actually, our team back in Boise is trying to punch holes through this, trying to identify a different control population that we can use to actually run along with this. And I don't know if anybody has done anything like this. I'd be very happy to hear how, and if you have any suggestions or thoughts on how to run controls on this patient population. But that is what we need to do before we can actually just go out there and have a party.
As you all know, that's very important for carrying the program forward, is going back to our decision makers and sharing that with them. And I love how you put it, after we punch holes in it, and that's our finance department. Okay, in terms of the patient experience and what they're reporting, here is a survey that we did early in the program, and we were doing it as part of a research project. There were 9 questions that were given to the patients who were in the program. Those are listed on the left-hand side. Overall, my interpretation is that most patients agreed somewhat or almost strongly agreed with all those, so somewhere about a 3.5. So they're very satisfied with the program. What I really liked seeing was at the bottom, there was one other question, and the scale was a little bit different. Instead of a 1, 2, 3, 4, the scale was much worse, somewhat worse, unchanged, somewhat better, and much better. 75% of the people who participated in the program said that they somewhat agreed, that they responded somewhat or much better for how is their health now. So hearing from patients, that's just a big summary of data. We have stopped doing this questionnaire, this survey, and we're going to more of a patient-centered survey. But this is another good indicator of those different measures. Better care, better health, lower cost. But you know, we all know about the 31 measures that we have for the program that are required to submit on a quarterly basis. I'm not going to get into those. We have the goals, and we have those set. But let's go down to the process level. And you've probably seen something very, very similar to this. This is for our Care of Patients at High Risk program. It's the basic phases that a patient goes through. When the patient gets recruited, we had that 50-some% recruitment rate, 90% enrollment rate. The purple are the care phases. And so what we did is, and I just saw it in an earlier presentation as well, and I was taking note of how much time is spent on those care phases with patients. And if you add all that up, it doesn't come out to very much time spent with a patient per year. And then if you multiply, just real simple, in our executive medical director and sponsor, when I showed him this, within about 2 seconds, he goes, "Oh, Steve, that's only about $600 a patient per year." And if you reduce that PM by that much, $500, you've paid for the program. The one in the middle is the active care phase, and that's after the person's come in, they've done the super visit, now they're going into the come in and visit with the care coordinator, or the care coordinator visits with them, 30 minutes, 1.5 times a month, plus we added in a couple of hours appointments for 11 months. So when you start to stretch it out, you can kind of see how involved the whole process is. If you were to simulate it, what you'd see patients coming in on the left-hand side, and they'd be going through here, and you'd see the ones that spend time in there, and you'd see the 11-month time frame, 12-month time frame. And then you'd also see how many nurses, how many care coordinators, how many social workers, LPNs, PCPs that you would need for that. The last one is sustainment. We talked about, do we want to call it maintenance? But the idea is the patient is improved over that time frame. They've gotten their health back in order. They're back on their medications. Some of their illnesses are gone away. Their behavioral issues are subsiding. And then ultimately the goal is we go to the green one, which is graduation or disenrollment. But from that, we've had teams that then take that and then they drill down and go to the sub-process level. This is just an illustration, as you've all done in your organizations. So for each one of these boxes, this is the sub-task, and you can just start drilling down and start gathering the data. Cycle time, value added time, who does it, how much time spent, what the labor costs are. More importantly, at the bottom, what can we do to make it better?
So there are a couple cases. We can go through these cases, but I figure you all have cases like this, these very complex patients. I can tell you, just very quickly, one, we had a lady, actually she's not in co-partner, she's in complex care management. She was in the hospital almost like 4 months last year, and she spent about 4 months in the hospital every year for the last few years, and we identified her, we connected her with a series of resources, and she was actually in the hospital twice already this year, but this is the first time that she was out of the hospital for over 60 days. But anyhow, she's actually a co-partner patient, so, but that required a lot more resources on our part, working with co-partner, with home care and other members of the team. So that's just, it really kind of helps us. We try to start some of our meetings, obviously, with patient stories to really keep us centered as well. These are just some quotes from physicians who actually find the services very helpful for the care of their individual patients. These are 2 of our internal medicine doctors. And these are just some shared lessons, and you heard some of them. So like enrollments were lower than planned. There's some physician engagement, particularly initially when co-partner was launched, but I think those have been largely overcome actually as they see the value to their patients. There's registry management, and Steve brought up the issue, particularly at the end, actually in the beginning of this year when there were, the data flow kind of dried out a little bit, and we did some troubleshooting of that. And then information systems and data analytic constraints, the timing of data flow, and then some leadership challenges, which I kind of mentioned a little bit earlier, where we have just basically due to the nature of our organization, how we've grown. We have a variety of programs that are doing care coordination. How do we coordinate all these programs is really a challenge because we want to be able to increase our footprint without having to hire additional staff and really just leverage what we have, but that is obviously a challenge in itself with each one of these programs. So
I got to see Don Berwick do a presentation. Don Berwick at that time was still with, IHI before he went to CMS, and he had something that's just stuck with my mind. And And I'm an engineer, so I love data. But on the other hand, his words go in my mind, and something like, you don't have to have statistics to know that it's dangerous to play on the highway. And so I think there's that fine balance, and we wrestle and we present the case, and that's where I go back to the shared lesson is on the leadership. You really need strong leadership to get through this transformation. It's not easy, but it's the right thing to do.
The first slide deck I'm going to share with you was presented by Dr. Melissa Marshall from Community Health Center Network and Brenda Goldstein, Lifelong Medical Care, one of the Community Health Network clinics. So I'm going to share the integrating primary care and behavioral health, part of a larger population health strategy. So the total cost of care of analysis, the analysis of the Anthem total cost of care reveals that costs are concentrated in patients that have 1+ hospital admissions and 3 or more chronic conditions. So you can see that the top 4% of the patients are responsible for 50% of the total cost, and they have the following characteristics. So we have total cost, number of patients, and then patients with inpatient admissions. And notice the higher prevalence of bipolar, CHF, depression, diabetes, hypertension, and COPD. The next slide is predicting the inpatient admission. So to predict future inpatient admission, CHCN developed a claims-based risk selection process based on select ACG codes. So we looked at hospital, inpatient, chronic condition, and then risk predicted per percentile. And then the analysis shows that a patient with this criteria is 50% likely to have an inpatient admission within 12 months. Her medical conditions are listed, her interpersonal behavioral conditions, along with her environmental or social conditions. This patient, her center goal was an aspiration to dance as far as what was affecting the patient. So access to care, self-management, food security, and pain management. This allowed CHCN to really understand who are their patients and what was the makeup of these patients so that they could identify the types of needs that these patients would have. Conducted 30+ interviews in March and then April of high utilizers and inpatient admissions according to claims. So the interviews encompasses the environmental, the historical, and social factors of the demographics. Key elements of the neighborhood with the care coordinator and the management team is the primary care, specialty care, behavioral care, and then the community-based resources and services to help support the patients. And the care neighborhood model, which is an innovative program for CHCN's most complex patient, is the patient and the community. Assess, stabilize, and empower and support the patient utilizing our community. And the care neighborhood will be built upon the IOCP model. So CHCN's goal is to enroll 500 patients by April of 2015 according to the following enrollment table. And given the caseload of 100 patients per staff member, fully built out a team which consists of 2 LCSWs, 3 community health workers, and 1 RN consultant to help with the medical issues. Key goals are scalable, cost-effective interventions, drives the net savings. The claim selection is one part of an overall patient selection process. So the primary mechanism for selecting patients will be claims-based with clinical review, and the approach also allows for referrals from clinicians with a claims review before outreach. The CHCN program is going to support the community integrated health care, so with the patient and the community in the center, and then reaching out to the different providers of care, the transition of care, the care team, care transitions from hospital to home to the community. Newly embedded care managers at the health centers will be responsible for coordinating care of these patients when they are discharged from the inpatient setting. Care team transformation from shortage of primary care providers and high rate of provider burnout and turnover within our clinics, and we want to transform the patient care team process. At one of the pilots, organizations, which is the Access Community Health, by July of 2014 to improve preventative care delivery and access to care, address the need to increase patient engagement, prevention, and chronic care management, while addressing over-reliance on providers to deliver standard care elements. And the focus will be on increasing preventative care screenings and increasing average patients seen in per day by 15% through the restructuring of care teams and implementing the process of planned visits. And integrating the behavioral health in primary care. So this is going to be a collaborative, team-based approach with embedded behavioral health clinicians in the primary care setting. So using LCSWs, PhD, and psych will be the care coordinators. The next slide deck that I'm going to present, that was presented by the Community Health Care Network, was from Brenda Goldstein. So just as an interesting fact here, we started with kind of the life expectancies. So with the US having 78 years of age, Japan 83, Mongolia 67, and then Ethiopia 53 years of age for their life expectancy. But people in the USA who have serious mental health issues, their life expectancy is 46 years old. So why do we integrate care? So the theme is, with people with serious mental illness, they die earlier than the general population, 25 years earlier. And they're 3.4 times more likely to die of heart disease and 6.6 times more likely to die of pneumonia and influenza. And the people with chronic disease, 7 out of 10 leading causes of death are heart disease, stroke, respiratory, accidents, diabetes, suicide, and they have psychological or behavioral components. The cost benefit with medical and behavioral health. So patients receiving depression care in integrated models are 54% less likely to use the emergency department. And after a review of 57 controlled cost offset studies found that integrated care resulted in an average of 27% cost savings, and a targeted psychosocial intervention with high utilizing Medicaid primary care outpatients found that medical costs declined by 21%. And that was at 18 months compared to a rise of 22% for those not receiving any treatment. The hallmarks of integrated care are multidisciplinary staff, patient-client driven goals, so it's patient-centered, shared space, shared records, informal and formal communication. So we have warm handoffs, hallway consults, case conferences, and using the electronic health record and emailing. So integrated care directly addresses the triple aim and promotes a patient-centered health home. Consumer satisfaction is very important. So consumer experience for almost any problem, they are in the right place. We want to make sure the patient plus the community equals a happy patient. When it's coordinated systems, coordinated medical and behavioral services, detection, treatment, and follow-up of physical and behavioral conditions, and linking them to specific resources that meet their needs. Staffing considerations, so you need to look at who is on the care team, what is their training, how does behavioral intervention fit into the clinic flow, and traditional mental health treatment versus shorter-term behavioral change focus care. So, what's important to the patient and what do they want to work on. Utilizing non-licensed staff, so recruit from your community. These are the folks that know the community the best and can be that resource and relate to them on, just living experience, language, and culture. And that's a huge advantage to engaging with these types of patients, is when you have staff that understand them, and especially cultural level. They're, less expensive than licensed staff. They're easier to hire, and they're very trainable. Other options for non-licensed staff is to expand the role to provide health coaching. So use your medical assistants. These are the folks that are already in the clinics. They know the patients well. They already, have established relationships with the patients. So utilize the medical assistants that you currently have and train them up. And hire them specifically for these roles. Of course, the challenges can be, the training, who's going to conduct the training and who's going to be supervising these non-licensed staff. but they can be very beneficial to the team. So training the staff, the licensed staff and the non-licensed staff, and in brief intervention models and behavioral activation, same-day behavioral intervention. So what's going to work best for, you know, a short-term and long-term. You know, and evidence-based for depression and alcohol use. So use what's proven to be, you know, best practices for, that's evidence-based for depression and alcohol use, and for a wide range of health issues impacted by behavior. And then linking with the community resources. Know what's available in your community and have that, you know, worked out way before you start your program, so that you have that at your fingertips. You know who to go to, and meet with these people, meet with the different agencies that are out there, and vet them as well. You know, establishing relationships so that you know when you need something, you can pick up the phone and call that person, and you have that established relationship. You know, inviting them to your organization, have them come over to the clinic so that you can meet, you know, face to face and build upon that community resource relationship. And the internet's also a really good use for consumer support groups. So that's another resource for patients to be able to talk to other patients, and tapping in to patient and family knowledge in a group setting. You know, you can also utilize volunteers and interns and residents, you know, within the community. You know, if there's nursing schools or behavioral health, you know, residents that can come over and help out at the clinic and learn something, but also support your needs for augmenting your staffing model. And specialist consults that could be available perhaps by phone, and utilizing them, and then also telemedicine is another idea and concept to utilize for linking specialist consults. And then financing a collaborative care, so you have to address your productivity issues, you know, same-day visits versus group visits, and what does it cost to provide behavioral health, mental health diagnosis only, or are behavioral interventions for chronic disease billable? So you need to look at your financial short-term and long-term goals with addressing your behavioral health, you know, issues with your patients, and participation in any shared savings with behavioral health interventions. Can those be utilized? So just some different ideas. And then utilizing data and IT. So how does your electronic health record support collaborative communication and care between, you know, your staff and your patients? Also think about protecting, you know, the HIPAA with health information between different agencies, and the impact of mental health services on the physical outcomes and utilization is very important. Most of our programs are showing that you have to, you know, address the mental, behavioral, psychosocial before we can even start working on medical components of, you know, and needs of the patients. And, you know, can we track process and outcomes and financial impact from integrated care, from, you know, all that we're doing? You know, how do we track that? What do we track to show that we have positive improvement, that we have positive outcomes for our patient and for our organization and for our staff? Next breakout session was delivered by Epic Management, located in Southern California. Dr. Charles Payton is the medical director. I'm going to go through his slide deck. The Epic Management was established in 1995 by Beaver Medical Group. It managed care support for 7 medical groups and IPAs. Beaver Medical Group is one of the sites that Epic Management manages. They also manage 7 other medical groups and IPAs. They have a limited Knox-Keene, and it's a global risk contract for both commercial and senior products, and they have a strategic partnership with Loma Linda Health Sciences. And the mission for Epic Management is to deliver exceptional quality healthcare management, professional and support services with a firm commitment to excellence, integrity, and innovation, making a lasting difference in the lives of patients and our communities. The IOCP project, through Pacific Business Group on Health, signed on August of 2013. They are targeting for 1,500 patients by June of 2015. And the project team was established October of 2013. The project manager came on board in January of 2014, and Epic started enrollment on March 2014. Eligibility population for the IOCP program were the special needs patients designated for high risk by health plan, and direct referral from the primary care physician could be Medicare fee-for-service, Blue Shield, Unida, Humana, Intervalley Health Plan, and SCAN, and then also utilize future selection on risk stratification. Initially, the first plan for EPIC was originally developed in 2013 to embed care managers within the primary care physician sites. They started with 3 of the primary care physician sites, and the 2014 budget allowed for 4 ambulatory care coordinator care managers. Enrollment was too limited with this staff level. Went back to the table and reassessed and decided for IOC's second plan, which was to add disease management nurses to the team, and then all care managers became cross-trained in the intensive outpatient care program model. Standard operating procedure for all of our case managers was the IOCP model. It was staffed by all RNs, and the distributive model was to have care managers in one central location, and then the patient stays with their PCP, and then the patients are dedicated to the PCP and the care manager. Now, enrollment was still a little bit too limited. Look at what are the essential elements of the workflow for each case. How long does it take to complete each of the enrollment pieces, such as the intake and super visit and the assessment, such as the VR12 and the PHQ and the PAM? And then what level of licensure is required to complete each of the tasks for the IOCP care model? Epic Management developed a spreadsheet that would populate specific fields and requirements, and it really allowed Epic to analyze licensure and task and really come up with a sustainable formula moving forward. This was really helpful, and Epic is sharing this with the rest of the IOCP groups. So I'm just going to briefly go through the next slides. If anybody's interested in having access to this Excel spreadsheet or more information, you can contact Pacific Business Group on Health. But it's a wonderful matrix, and we heard a lot of positive feedback from the attendees of the CQC IOCP learning session about this. The next breakout session was presented by Dr. Mark Steffen. He's from Dignity Health in Phoenix, Arizona, for the ACN, which is the Arizona Care Network. Dr. Steffen, his slide presentation was addressing in the trenches, ambulatory care, redesigning, and moving towards clinical integration. The path to clinical integration at Dignity ACN. So today they have a network of 610 primary care physicians. They have 1,711 specialists, 89 hospitalists, and 38 different electronic health records. So the activities that ACN started with was the practice redesign, care coordination, population health management, and information exchange. So these were their 4 buckets of work streams. So with the care coordination program, they wanted to develop multidisciplinary care teams with a PharmD, a nurse care coordinator, an LCSW, and a community resource aide. The services provided by the care team would be a medication review, patient education, treatment plan creation and education, so patient-centric, shared action plans, and remove barriers to care. So this is a graphic, a display then of the clinical redesign, of having ongoing physician leadership, EHR that's supporting all the sites with secure messaging. There's quality and accountability and care coordination. And then inside that is the certified medical practices who have same-day appointments, that have dedicated personal provider and an office navigator, and that there's patient data where and when you need it, so that everybody has a 360-degree view on the patient at all times, and all the information is there for everybody that's involved with the patient. So they're exchanging information, they're sharing information, and being still, very patient-centered focus, and having access to primary care.